Okay, so we left off talking about, we're still talking about some high risk categories. And I will mention C-section because these can come into the ER, these can come into a GP. Um, and usually when they come in, once it's deemed the mother can't be induced and you can't manually take out a pup, then it's typically an emergency. And typically the mother, and C-sections can vary because sometimes you'll have a planned C-section, like the breeder of a French bulldog doesn't even want them to try to go into labor. Or she's coming in and she's in such poor condition, she's weak, she can't deliver the pup. So the mother's condition can fluctuate. Sometimes they're not fasted because this wasn't planned. And so we have to also be cautious because any anesthetics do cross to the fetus. So we don't tend to use a lot of heavy opioids like morphine and hydro. We use like butorphanol or buprenorphine. You can do a line block. We try to use low, gas concentration because, again, a lot of times the risk here is that the puppies, the kittens, or whatever is going to be potentially respiratory or cardiovascular depressed. And a lot of times the mother can also go into shock due to the fact that the uterus somewhat compresses blood flow. And let me pause here. Sorry, Bethany, I just saw your comment. You don't really need to bring anything with you except maybe to take some notes. I will have a handout that I'm going to give you guys on Thursday. It's kind of like an anesthesia flow sheet, like all the typical duties of an anesthetist from pre-op to post-op. So I'll be giving you that, and then just maybe a notebook if you want to jot some stuff down, because I'm going to go over drugs and some common effects and things to look for. So time is of the essence on a C-section, and be prepared to do resuscitative methods. You may be, because in ClinMed 5, and maybe you've talked about a drug called Dopram. Dopram is a drug that's a respiratory stimulant. It's sometimes used in cardiac arrest, but if you have the puppies or the kittens come out and they're not breathing, you can take a small, like a 1 ml syringe, and inject a very small amount, like I'm talking maybe like 1/10 of an ml under their tongue. Now, you don't drip it under their tongue. You actually take a needle and inject it in the ventral aspect of the tongue, because you really can't hit a vein in these neonates. So sometimes that will get them breathing. You also may give them Narcan under their tongue, because if you did use opioids, you could potentially reverse the opioids. So that's kind of what we have ready for the pups or the kittens when they come out. And then after the last pup is removed, sometimes we will give the mother a more potent pain medication, but sometimes we'll start with light drugs. Once you get the last pup out, then you can give the mother more drugs because they're no longer inside and we have more options. As far as animals with hepatic disease, hepatic pertains to the liver, and the liver is responsible for breaking down all of the drugs. So, drugs can last longer. We may need to decrease doses. Ketamine and diazepam particularly go through a fair amount of metabolism. So I would probably avoid those drugs. Propofol is a really good choice in hepatic disease, and alfaxin, because both of them go through little kidney or liver metabolism. They are broken down, and so they're not taxing on the liver and the kidney. You don't want to not give them pre-meds, but we generally try to use lower doses when at all possible. You also, anytime you have a liver patient, you have to worry about protein levels. You have to worry about clotting factors. Now, clotting factors don't interfere with anesthesia, but if you're doing surgery, we want to make sure that they can clot. And also, the liver produces proteins, which protein binding drugs, and an animal that's low protein, that can affect the way drugs are redistributed throughout the body. And then as far as kidneys, kidneys are responsible for fluid balance and electrolyte balance within the body. So, and the kidneys, typically, now kidneys don't usually break down drugs, they excrete them. So usually the liver metabolizes the drug, and when a liver metabolizes a drug, there's two forms. It can be an active metabolite and it can be inactivated. Like when I told you ketamine in the cat, ketamine is excreted as an active drug. The liver doesn't really break down ketamine in the cat. In the dog, it's about 50-50. So sometimes the kidneys are excreting an active metabolite, which means that drug is still active. It still has the ability to sedate. So usually liver kidney patients, I also worry about recovery. Are they going to have a prolonged recovery because it's taking their body longer to either break down or excrete the drug? And therefore, if I use lower doses, hopefully that improves recovery. The other thing we worry about is general anesthesia. Typically, because it causes hypotension or can decrease perfusion, in order to maintain kidney function, you have to maintain decent blood pressure, a minimum of 60 for a mean blood pressure to maintain blood flow. And as long as blood flow goes to the kidneys, they are excreting drugs, they're maintaining perfusion. Now, again, and you guys, this will be important for surgery, is you are running blood work on your patients before surgery. We specifically usually want at least a BUN, which is a blood urea nitrogen. A creatinine is a more specified test. So like if you have an elevated BUN, you would run a creatinine, and a creatinine would give you an idea of how advanced the renal disease is. So it kind of backs up your kidney values. And then obviously your urine specific gravity is important because that's the kidney's ability to concentrate urine. Remember, if urine is dilute, it's not concentrated. So if you have a low specific gravity, it could be an indicator, either they drank gallons of water before they came in, or the kidneys aren't concentrating. It's always also best to do that urine specific gravity first thing in the morning because that's their most concentrated sample. So sometimes we'll have an owner bring in a urine from the first, because it's hard to get your dog to the hospital without letting it out in the morning. So sometimes we'll have the owner do a free catch, bring in the urine, and we can do a USG when they come into the hospital. Typically these guys, we also, very important, if we are borderline renal disease, you don't want to withhold water in these patients. And I've told you this, most patients nowadays were realizing it's maybe better for them to eat closer to surgery, but especially for them to have access to water. The only time, and I always ask owners, I'm like, most cats don't guzzle water. Now, you might have a dog that's a guzzler, and if the owner says, oh yeah, he drinks gallons of water in the morning, we'd maybe withhold their water. But as long as they're just kind of getting a normal size drink, we usually let them drink all the way up into surgery, because getting water is maintaining fluid flow and to the kidneys. You can correct any dehydration prior to anesthesia. So they may need fluids before the dental, before the surgery, is also beneficial. Then this is kind of going, this is going back to C-sections a minute. Some of these got out of order. I apologize. These are other some problems that we have with C-sections, is they are also prone to aspiration. Um, the weight of the uterus is pushing on their stomach. And because it's pushing on the stomach and then we relax them with anesthesia, it may push some of that stomach fluid up into the esophagus. So you want to look for regurgitation, especially. They have decreased lung capacity due to the fact that the uterus is pushing on the diaphragm. So it kind of decreases their thoracic capacity. So we have to watch their breathing very closely. Um, Increased cardiac load because you have the blood flow of the mother, but also you have to maintain blood flow to the fetuses that are in utero. So we're maintaining blood flow, and that increases workload on the heart. So we want to make sure we have good heart rate, good blood pressure, because the weight of the uterus on the vessels in the abdomen can compromise blood flow. One thing that's a practical tip, and sometimes you guys remember this and hopefully you're awake, is when the uterus is pushing on the vena cava. So the vena cava is the large vein that brings blood from the abdomen back to the heart. It's return of blood flow. If you have a uterus sitting on the vena cava, it's potentially obstructing some of that blood flow. Usually when I prep a C-section, I never laid them in straight VD. I would always lean them to one side or the other. And that was to try and keep the uterus, because the vena cava runs along the spine in the very deep abdomen. So if I tip the dog, then I'm kind of keeping the uterus a little bit off of the vena cava. And I didn't put them on their back till right before the surgeon came in the room to do surgery, because the doctor does need them directly in VD. But while you're in the prep room, you can put them kind of tipped. And when I prep them in the OR, I keep them tipped. And then as soon as I see the surgeon walking to the room, I would pull the dog straight. And then that at least helps a little bit with the blood flow, especially if they're a very large dog. We know there's a lot of pups and a heavy uterus. And a cat, it's maybe not as much of a big deal, but, for them, a cat, if they've got 5 or 6 kittens in there, that's a pretty significant uterus for a cat. So it's beneficial. Generally, you can use lower dosages because they are typically in a compromised state. They shouldn't need as many sedatives. And hemorrhage can be common because of the large amount of blood flow to the uterus. Their tissues need to be more friable, a lot more bleeding. As far as protocols, I kind of explained, neuroleptal analgesics, like a hydrovalium protocol. You could do, although hydro depresses the pup. An epidural can be done if it's a very healthy mother. That's added analgesia. The problem is it takes about 20 minutes or so to do an epidural. So you're adding 20 minutes of anesthesia because they have to be under general anesthesia to get an epidural. So a lot of doctors aren't going to want to spend the time to do an epidural. They'd rather maybe do a line block, and we can do a line block. A lot of times when the doctor is scrubbing, I do a line block right before they come in the OR, which will still give added analgesia, but it doesn't take as much time to do a line block versus an epidural. Oxygenation is good. Propofol and alfaxin are probably the best induction agents. Ketamine is going to hang around a little bit longer, potentially depress them a little bit more. So I don't know about ketamine. And then we try to reverse, at minimum, we reverse the neonate. I'm not a big fan of reversing the mother because you just did major abdominal surgery. We need to give her good pain meds. So unless she's very ill or very critical, we will usually try to leave her drugs on board and not reverse her. But when the pups come out, you can give them the reversal agent. And we tend to not use alpha tues. They're really potent. So we're talking like the midazolam, diazepam, propofol, alfaxin. All of those are very light anesthetics that don't hang around for a long time. And then again, I've kind of explained this, is that they can be hypoxemic. Hypercarbia is a high CO2, and they tend to have hypotension, which is low blood pressure. Physiological anemia, due to the blood being also consumed or being used for the pups, sometimes it drops the mother's PCV. And it's not that she's primarily anemic, but due to the compromised blood flow, the puppies, they kind of call that a physiologic anemia. And we have to watch for cardiac arrhythmias due to the compromised blood flow. So I'm not talking about the puppies right now. I just kind of want to talk about anesthesia for the mother. As far as trauma patients, trauma is a very broad category. This could be a dog fight. This could be a hit by car. Those are probably the main traumas. I mean, an animal could fall from, like a cat tries to jump off of a cabinet and falls to the floor. That is even a form of trauma, getting stuck under a garage door. But if an animal comes in on emergency with a trauma, they're automatically in an anesthesia risk. What we really worry about is respiratory effects. So a lot, especially in a hit by car, if an animal is whacked by a car, you got to think about what happens to the lungs and the chest. They usually get jostled, and they can potentially rupture some lung tissue, which causes a pneumothorax. Now, a pneumothorax is air that escapes from the lungs into the thorax. And if you remember, the thorax is supposed to be negative pressure. When air escapes out of the lungs, it adds pressure, and it creates what's called a positive chest. And that air will actually push down on the lungs and not allow them to expand. And a pneumothorax is probably one of the first things that has to be assessed and treated in a trauma. Now, a pulmonary contusion is like a bruise on a lung. If the lungs get bumped and there's a bruise, which you can't see unless you open the chest, but if you have an animal that's having difficulty breathing and you rule out pneumothorax, when the lungs bruise, the alveoli some alveoli can fill with blood. And if they fill with blood, then they are not going to be able to expand and exchange oxygen. So that can cause difficulty breathing. We do worry about bleeding into the chest from a lacerated lung or lacerated vessel. Also, if they do get hit by a car and they tear their diaphragm, that's called a diaphragmatic hernia. Now, if you remember, the diaphragm splits the abdomen from the chest. If that diaphragm tears, then what can happen is abdominal contents can come into the thorax, which also impedes ventilation. And that is a surgical emergency. You have to do that right away. Now, decreases VT. That VT stands for tidal volume. If you remember, tidal volume is the amount of air moved in one breath, in and out. If their thorax is compromised, they automatically can't breathe in as much air. And if we decrease tidal volume, we can lead to hypercarbia, we can lead to hypoxia, and that affects oxygenation. Increased CO2 leads to that acid-base imbalance. Remember, when CO2 goes up, pH naturally goes down. And when you have a low pH, you have acidosis. And remember, I said to fix that, you ventilate the patient. But you cannot overventilate an animal if they have a diaphragmatic hernia, if they have a pneumo, pulmonary contusions. All of those situations, we have to be very cautious with ventilation. So we have to really find out, number one, when a trauma comes in, is there any issue to the thorax or breathing? And we worry about hypotension because if they did lose blood, or fluid sequestration. What that means is, say they bleed into their thorax. They have not lost that blood, but it's sequestered or trapped in a different spot. Now, it does not go back into the vessels. Technically, you would suck that blood out of the chest. They may need a transfusion to replace that blood. But fluid sequestration means fluids in the body are being trapped in areas that they're not supposed to be, that can't be accessed. And therefore, we can have anemia due to blood loss, or we can have anemia because it is trapped and we can't get it. So probably number one is try to stabilize them. Um, a true story, I was working ER and I was working with a newer vet, and she was great, but she was kind of, sometimes we call them baby vets. And we had this dog hit by car, and its leg is kind of like dangling. There's an obvious fracture. There was road rash. The leg looked awful. And I was listening to the heart, and I was like, it just sounded like an abnormal rhythm. And I'm like, okay, we got to get an EKG. We should probably do some chest rads. And she's like, we got to sedate this dog. We have to like clean the wounds. We have to bandage the leg. And I'm like, well, and she was kind of focused all on the leg. And I'm like, I don't know, like, this is weird. And we put the dog on an EKG, and it was having runs of abnormal rhythms, BPCs, some tachycardia. And she was like, oh, wow, I'm glad we didn't go ahead and sedate that dog. A dog is not going to die from a broken leg. I mean, unless an artery is pumping in the air. What we did was we just put a quick wrap on the leg. We did protect it and stabilize the limb so it wasn't like dangling. And then we put the dog on some IV fluids, on some nasal oxygen, and it stabilized for 24 hours. And the surgery was scheduled for the next day. And the dog's arrhythmia improved. Because the arrhythmias can come from shock, arrhythmias can come from hypoxia. The dog had a slight pneumothorax. So, everybody tends to focus on the outside of the dog and be like, oh, that leg looks terrible. There's sometimes trauma patients would sit in our ICU for 2, 3, 4 days till we resolved a pneumothorax, till we resolved their shock. They got a transfusion. I mean, you don't want to rush into an OR with an unstable patient, because again, they're not going to die from that broken leg unless they were bleeding. And this dog was not. I mean, there was wounds, there was blood, but it wasn't like an artery is pumping in the air. The dog was not further losing blood, but obviously the dog had some shock and had some contusions to the heart and causing these arrhythmias. So we put the dog on some pain meds, fluids, nasal oxygen, stabilized it, was able to go to surgery in 24 hours. So in a trauma, that's probably the most important, is make sure you stabilize, make sure you look for obvious, some internal problems. So that's why you got to watch for dyspnea, any change in that respiratory effort, in that pattern, any arrhythmias, and also altered mentation. If the dog comes in and they're kind of aware, and then all of a sudden they're not responding to their names, they look overly sedate when you haven't given them drugs. Head trauma sometimes isn't apparent immediately. If there's a small brain bleed and then blood is starting to accumulate in the cranium and you start to see altered mentation, then that's going to be a problem. So I mean, I've seen hit by cars walk in the door because adrenaline is a good thing, and they kind of come in like, okay, and then we put them in a cage, and then all of a sudden they crash like an hour later. So I've seen all kinds of presentations, so you just need to be aware. You always need to be on guard. You never know when they're going to decompensate. You never know when things are going to change. And that's why, you know, you can do a quick thoracic radiograph. That's going to look for fluid. That's going to look for air, things of that nature. As far as respiratory problems, usually what you need to do is give them oxygen therapy. The other thing you can do if they have a pneumothorax is you have to evacuate the air. You have to remove any air and fluid from the cavity. Now that can be like with what's called a chest tube, which you put in, and that allows you to pull air out multiple times. Sometimes we'll just put a needle and do a temporary evacuation of the chest. It kind of depends on how bad the pneumothorax is. I've seen patients where we pull some air out and it fixes the problem. But if they have an active leaking lung, you pull air out and in an hour, the chest is already full again. That's the type of dog that's going to need a chest tube, is because air keeps filling the thorax quickly. Some ways to stabilize and give oxygen. Here's a picture showing this dog is on what's called bilateral nasal oxygen. So these are urinary catheters. We use them also as feeding tubes and nasal oxygen. They are in the nose, but they just go as far as the medial canthus. This just goes in the nasal cavity, and then they are usually sutured here and usually taped and sutured to the head. Now, normally that suture, they're not anesthetized for this, but a dog that needs bilateral nasal oxygen is probably not reacting to a suture being placed, believe it or not. And then these hoses are hooked up to a flow meter and oxygen. Now this dog, they made like a little oxygen tent. They put an e-collar, covered it with saran wrap. Now normally you have to poke a little hole because you don't want to trap CO2 and moisture. And what they've done is they've put the oxygen tube inside and they've made like a little oxygen tent. In our ER at VCA, we have oxygen cages, and the cage has a clear plexiglass front, and the animal can be free and it fills the whole cage with oxygen. So, you know, usually an ER is going to have an oxygen cage, but if you don't, or you can do these other methods of oxygenation. And then if a chest tap or thoracocentesis is usually done, you know, most of the time the vet is doing this with help. I'm not going to get into the whole procedure. Maybe you've talked about this in ClinMed 5, but basically we go between the 7th and 9th intercostal spaces. We usually use about a 4 to 5 inch needle, and we usually use our criticalist. He had 14 gauge 5 inch catheters, so he would poke through. You got to get through the skin and the 2 layers of intercostal muscles, and then you go through the pleura. Well, that takes, depending on the size of the dog, that takes a good maybe 1.5 or 2 inches. And then what he would do once he got into the pleura is he'd thread the catheter, and I would hook up an extension set with a syringe, and I would start pulling. And depending on, if we suspect fluid, he would put the needle low. If we suspect a pneumothorax, he would put the needle high because air rises and fluid settles. So usually the dog is in sternal. That's what's best. You don't want to put them in lateral. Usually they're in sternal, and we pull the legs forward because you got to get into those caudal rib spaces. Is there any reason we wouldn't put it between the 4th and 7th rib spaces? Why do we go all the way back to rib spaces 8 or 9? Why not go right between 4 and 7?
Isn't it because the heart's located there?
Yeah, thank you. We want to stay away from the heart. You don't want to hit the heart with that big needle. The heart doesn't like that. You can actually induce some arrhythmias if you accidentally touch the heart. So yeah, if you're doing it for a pneumo or fluid, you want to be at the 8th or 9th caudal rib spaces. Yep, thank you, the heart. So Madison said it too. Yeah, got to get away from the heart. So, and remember, air is dorsal, fluids ventral. And then I will just mention that cardiac arrhythmias, this is very broad. I'm not going over all the different types of arrhythmias, but it's very common after trauma. And it depends on how bad the trauma was. But like I said, I've seen patients in the ICU for 2 to 3 days. We can put them on what's called a continuous ECG, where we're keeping EKG on them. And sometimes, you know, sometimes you need medicine to control an arrhythmia, like lidocaine, a drug like propranolol. There's medications that control specific arrhythmias. Sometimes they just need oxygen therapy, pain meds, and rest. And the heart will kind of heal and the arrhythmias will get less frequent. So not every arrhythmia is going to be treated with medication. Sometimes it's just going to be observation. And the big thing to remember, this is I hope a light bulb moment. The heart's job is to pump blood and to maintain perfusion. Anytime we are evaluating cardiac arrhythmias, we have to monitor blood pressure and perfusion because, like I said, the criticalist I worked for is anytime we had an arrhythmia, and I used to freak out at every little arrhythmia. And he's like, Christine, what's the blood pressure? What's their color? What's their pulse quality? If all of that was good, he goes, then why are you freaking out about the arrhythmia? Obviously, the heart's doing its job. If it can maintain blood pressure, if it can maintain good color, good pulse quality, that's the job of the heart. So if it can do its job during the arrhythmia, sometimes we would just observe. Now, it doesn't mean we blow off the arrhythmia. It just means there's not always a need to treat an arrhythmia. Is the heart doing what it's supposed to do? If the heart's doing what it's supposed to do, then there's not a need to sometimes intervene. And that's important to assess because some hearts will get a little jostled and it doesn't cause a problem. But if you have an animal that's having an arrhythmia and having low blood pressure or crappy color or super weak pulses, those sometimes need intervention. And that's up to the doctor. Are we going to, put them on a lidocaine CRI, a propranolol CRI, or things like that? So the way we look at that is, you auscultate. Is it a normal rate? Is it a normal rhythm? Do you have a pulse for every beat you hear? Make sure you don't have pulse deficits. Do you have good color? And obviously, you usually have them on a continuous EKG or you do intermittent readings, one of the two. So let me say, I'm going to stop there because I know it's 8:42. What I'm going to do, I'm going to upload, I have a summary sheet of this section because I know there's several slides. Again, in this PowerPoint, we are not going over CPR because I know you do that in ClinMed 5. So I'm only really using this PowerPoint. How do we respond to some common emergencies? But I think tomorrow what I'll do, this obviously has more detailed information to summarize the chapter. My summary sheet is going to go over the sections that I want you to know for the test. And to review the final, this is the new material. Bovine and swine are going to be on the final, and then some stuff about anesthetic machines, some very basic stuff about anesthetic machines, which, we already went over that in the beginning, but because that wasn't on the midterm, I'm going to add that to the final. So if you have any questions, let me know. I'll get this converted and get that sheet posted to Moodle so that you can study. And then tomorrow we will review in the morning. Do you have any questions?